Good afternoon. My name is Cherie Boxberger, Senior National Director for Quality, Outcomes Research, and Analytics here at the American Heart Association. I would like to welcome you to the first webinar in our series, Expanding Access to Cardiovascular Care. Today we'll be focused on improving timely access to cardiovascular care with remote patient monitoring and introducing American Heart Association Connected Care, powered by Cadence. Before I introduce our panelists, a few housekeeping items. All our view are muted, and only our panelists will be on camera. If you'd like to use closed captioning, you can do that by clicking on the CC icon at the bottom of your screen. The session is being recorded, and you'll have access to this afterwards. You can put questions in the Q&A panel at any point. Don't feel like you need to wait until the end. And if you experience any technical issues, you might just leave and rejoin the webinar or double check your internet connection. We hope you'll stay on into the end of the Q&A, and there will be a copy of the slides in a PDF version that's in the chat here in a few minutes. So let me tell you about those who are joining us today to present. We're joined by Larry Allen of the University of Colorado, Donald Kostic from Frye Regional Medical Center, as well as Kimberly Godsey. I'll start with Dr. Kostic. Dr. Kostic is Vice Chief of Staff and Chief Hospitalist for Frye Regional Medical Center. He's also the Medical Director for Inpatient Rehab. He received his undergraduate training in Akron, as well as a medical degree from Northeast Ohio Medical University, and did his residency at St. Elizabeth's Health Center in Youngstown, Ohio. And he's held roles in both private practice as well as hospital employment hospitalist. And most important, he is the lead for the Connected Care Project for Frye Medical. Also joining us is Kimberly Godsey. Kimberly's a nurse practitioner specializing in heart failure and advanced cardiac care. She has her certification from HFSA, former Army National Guard flight medic, and she graduated from University of Cincinnati and brings her expertise in clinical areas along with cardiac psychology, focusing on both the physical and emotional aspects of heart disease. And then leading us off today is Dr. Larry Allen, Chief of Cardiology, University of Colorado, and co-director of the Colorado Program for Patient-Centered Decisions. He's here representing our System of Care Advisory Group, and he's also leads all of our research around that group approves. Trained at Harvard, Mass General, as well as Duke University, a member of the Colorado University Advanced Heart Failure and Transplant Team, and past chair of the AHA Clinical Cardiology Council. So I'll turn it over to Dr. Allen to kick us off.
Well, it's a pleasure to be here today. Thank you for having me. I wear a lot of different hats, as was just highlighted. I'm an advanced heart failure and transplant doctor, and spend about a third of my time actually seeing patients, including inpatients, and then helping transition them to clinic and actually often home to their local regional providers. I've also worked a long time with the American Heart Association on a number of initiatives around heart failure. That's included some of the quality metrics around readmissions. That got me involved in the Get With the Guidelines program. And as was mentioned, I now spend a significant amount of time every month working with the Systems of Care Advisory Group that overlooks Get With the Guidelines and the quality improvement registries around heart failure. I've also actually worked with AHA on how to think about expanding what SOCAG and the Get With the Guidelines program does. So there have been efforts to try and expand that outside of the hospital to help with transitions of care, which we're going to talk about, and to greater parts of our country and internationally. I've actually had the privilege of also working with 5 countries in Southeast Asia about how to handle these issues as well, which is provides some great perspective. So I don't know that I need to belabor the fact, but the impact of heart failure continues to rise. As the stats show here, heart failure remains the leading cause of hospitalization among Medicare patients and one of the most common causes of inpatient care in the United States. Heart failure patients experience 4 times higher overall 2-year expenditures than other patients, not surprisingly. And this total cost of care is estimated for the US to be about $50 billion per year by 2030. A couple of other thoughts I like to add about heart failure is that, in many ways, heart failure is the classic chronic disease, right? In this country, we are talking about whether you're listening to the new Make America Healthy Again stuff or other places, they're really talking about how in our country we have done a pretty good job of treating acute medical issues and procedural based issues. But what we've not done a very good job of is really handling chronic diseases that emerge from a variety of other issues that are playing out in our society. So, heart failure is classic in the sense that it increases with age. So these patients are often older, geriatric, with frailty. If you look at Get With the Guidelines, the average age of a patient admitted is now over 75 years old. So half the patients that we're dealing with are much older and have those kinds of issues to deal with as well. It's a common downstream result of lots of medical problems that need to be addressed. I often tell people you can't be a cardiologist and a heart failure doctor if you don't pay attention to the fact that your patient has a glucose of 600 and they're not managing their diabetes. That might help with diuresis, but it does not keep them out of the hospital and manage their heart failure. Reflecting that comorbidity is common. One of the papers that I worked with that I enjoyed the most was we looked at the comorbidities that patients with heart failure had, and it was about 5 on average. So you can say you're dealing with heart failure, but you're really dealing with a patient who is dealing with kind of a multitude of overlapping chronic diseases that all need to be managed well, or the patient is going to fail. You can't just look at one piece of this and think that that's going to solve it. This results in increasing polypharmacy, a term that I think is really catchy, but I think means a lot to us, is that we talk about polypharmacy, meaning that a patient is taking more than 5 medicines per day. If you look at the heart failure population, the average patient is taking 11 medicines per day. We call that polypharmacy, hyperpolypharmacy. And I think that term hyperpolypharmacy is really critical, especially as you think about taking a patient, having them leave the hospital, and then trying to manage 11 different medicines that have 11 different things that they're trying to treat. And then this is an undulating disease. We talk about chronic diseases being progressive over time, but it's not progressive in a linear form. It goes up and down. People feel good one day, they feel bad the next. And the question is, tomorrow, are they going to feel worse and need to be back in the hospital, or are they going to feel better again? And what can you do to change that course? That's a huge challenge to us in terms of how do we triage patients and deal with that. And then one of the great things about heart failure in the last few years is we have so many more medications, devices, and even monitoring to follow our patients. But that growth in what we can do for our patients has also grown the complexity of what we and our patients face in terms of managing those treatments and paying for those treatments and figuring out how to put them all together. So, um, I highlighted this a little bit, but we need to have a stronger system of care for heart failure patients across this continuum. So obviously, prevention and identifying early detection of warning signs for worsening disease is really important. But 70% of the costs and the care that are applied to patients with heart failure really happen in the acute inpatient setting, because that's where patients are really sick. They demand a lot of resources, and the readmission rates are really high, so patients keep getting back in the hospital. So thinking about how to break that cycle of hospitalization and readmission is critical, and we've been talking about that, I think, seriously in this country since 2009 when the public readmission metrics came out, and then in 2012 when the payment penalties for readmission came out in the HRRP. But how to figure out how to do that better, how to get patients to home and keep them there living healthy lives and not coming back in the hospital is I think, challenging and complex, but I think there's also a lot of opportunity for us to do better. So I mentioned this before, but the Get With the Guidelines program I think has been really successful. It's now been it's been in place for over 20 years. It's been a nice couple of publications that have come out and a few more coming out talking about the success of the Get With the Guidelines programs, including heart failure, but also for stroke MI, AFib. Um, the Get With the Guidelines program, importantly, though, is focused on the hospitalization event. So this is really a program, quality improvement program, that works with hospital systems, looks at the inpatient experience, and then collects data on these patients at the time of discharge. And I think it's done amazing work to try and help hospitals around the country share best practices and come up with what seems to work well in terms of improving the hospitalization process and making sure that it's efficient and that people leave the hospital in good treatment. But one of the downsides of Get With the Guidelines is that it's not really a comprehensive, continuous program. Once those patients leave the hospital, the Get With the Guidelines program doesn't follow them. It's also a retroactive program in terms of looking at what happens to patients after they've been discharged and then learning from that. But it only informs the initiatives that we have that we use the data to learn from. It doesn't necessarily create that. So. Um, so there is definitely room to think about how we can not only do just a better job of providing inpatient care, but also thinking about how we can do a better job of transitioning patients to the outpatient setting and creating more connected care, continuity of care. So the American Heart Association Connected Care program, which we're talking about today, powered by Cadence, is designed to integrate American Heart Association Connected Care hospitals, then create a comprehensive care pathway that supports their patients throughout the post-discharge health journey with remote patient monitoring and a virtual multidisciplinary team. And I think, again, what that does is it takes the strengths and the history of what the American Heart Association has done with Get With the Guidelines and other initiatives, and really tries to bring that to the actual patient in real time as they make these transitions and try and continue their care after they leave the hospital. So I'm going to turn it over to Dr. Kostic now to give us more details on this program.
Well, hello, everybody. I'm Dr. Kostic, as everyone said. I am currently in Hickory, North Carolina, and if anyone cares, I do see a little bit of snow out there, which makes me happy because, and it's only a little bit. So I'm from the north, so I love the snow when it happens. Anyway, we'll get to business. Proceed to the next slide, please. So I'm going to give a quick outline. We have a few things to talk about. We'll talk about the overview of Frye Regional Hospital, the challenges that we face in our local area, the AHA Connected Care pilot program that we're doing, and some of the things that we've seen in the key team members and the workflow that we're seeing and the progress so far. So next slide, please. So Frye Hospital is what you would consider kind of a medium-sized hospital, 355 beds that are licensed, 100 of them are behavioral health. So you have to take out that 100 and do work with 255. The staffed beds, about 170 acute that we have right now, and 20 rehab that I oversee as well. Average daily census, you see it there's 178. Average length of stay, 4.4 days. And some people that know the average length of stay will say that's a little high. Operating room, you see there, the ICU beds, step down beds, and ED beds. Please go to the next slide. The populations that we serve, there's an ethnicity distribution, which is very important to be aware of. Age distribution, as Dr. Allen said, there's a lot of patients that have heart failure that come in their 70s, and that's very apparent in our age group a lot. When you see the age distribution there, 65 plus is over 42%. That's just the populations that we serve, not necessarily the patients that hit the hospital necessarily. Next slide, please. So of the Frye heart failure population, if you think about the last slide I just showed you, the gender mix for our heart failure is male to female, 55.1% to 44.9. Ethnicity, 83% are Caucasian, 13% are African American, then a smattering of the rest. Average age, Dr. Allen, as you said, up to 75. We're seeing 73.08. Average length of stay is 5.8 days. That's actually improved over the last year from my hospital staff, but it's still a little high. Marital status you see there. And the traditional Medicare payer is up to 21%. And as Dr. Allen alluded to, this is one of the most expensive diagnoses you can have, and is definitely one of the most expensive diagnoses in our hospital. Please move on to the next slide. So here's where we see some of our challenges in heart failure at our location here in Hickory, North Carolina. And some of these are going to be exactly the same as in other places. So the beautiful thing when you're comparing heart failure management is everyone has incredible heart failure challenges in so many places. Some of the things you're going to hear is some of the same things you have. Some of the things you're going to hear is not going to be the exact same challenges. Um, Access and location, we have a lot of rural areas locally to us outside of Hickory. Hickory's not a very big city. Yes, you'll see some stuff on like US News and World Report that Hickory is a new and upcoming, nice little city in the middle of North Carolina or in Western North Carolina. The reality is we're not very big, but our capture rate of patients in this area is massive. We have people that live just outside of Charlotte that come to our doorsteps. We have people that live in the Pisgahs. We have people that are close to the North Carolina border that we get patients from. So we're capturing from a very large mix. And I always say higher acuity. I've worked in 1,000-bed institution and a 100-bed institution. This is one of the higher acuity hospitals that I have worked in. So sometimes you're diagnosing heart failure for the first time, and sometimes you've seen this patient for the 10th time this year. Patient transportation is always an issue, especially when we're trying to do follow-up and when they try to get to their medications. Our region includes, like I was saying, large rural populations, and they face. We have a set of patients that live almost an hour and a half away from our hospital, and it's really, really hard for them to get to their next appointment. Insurance and financial barriers. This is no different than most places. North Carolina has its own challenges with both Medicare patients, Medicare Advantage plans, Medicaid patients, other insurers. There's a lot of challenges that go into this. The medication cost, even though we have a boatload of medications, and I'm sure Dr. Allen and everyone else that's a clinician in the room that takes care of these patients and case manager will shake their heads. And some of these meds are very expensive, and we don't always get them approved. And the outpatient doctors, and this is something that you guys don't know, but my wife is an outpatient doctor, and she spends a lot of time trying to prior off some of these medications. It gets really, really difficult. And then we don't have a ton of cardiac rehabilitation slots, which is incredibly important for the management of heart failure moving forward. A big piece of their recovery is through cardiac rehab. Acuity of patients, everyone always talks about, well, I have the highest acuity patients. And that's true. A lot of places do have very high acuity. I think the big takeaway there is the acuity of patients has gone up over the years. And I think if I asked Dr. Allen and any other physician and APP and anyone else who sees patients in the hospital, you would say, yeah, the acuity for these patient base has gone up. The age of the heart failure patient has gone up. The amount of medicines they're on, the amount of comorbid conditions or HCCs, if some people know what those are in the room, CKD, COPD, diabetes, that it's uncontrolled. It makes these scenarios very, very difficult. And we see higher rates of volume overload requiring prolonged hospitalizations. We see patients that end up needing 10 days with help of nephrology, sometimes pulmonology and cardiology helping us managing these patients, increased need for a very aggressive IV diuresis and continued telemetry monitoring. So next slide, please. I think you went too fast. Challenges in our heart failure care, again, clinic availability, delays in scheduling. The 7-day follow-up is so hard to meet. We schedule it all the time, but it's very difficult to meet those metrics when you're having trouble with just having enough clinicians in the area. The socioeconomical barriers, everyone has stories about this. Low income population, you have difficulty, as I was saying earlier, purchasing meds, monitoring BPs and weights. Limited home support is a really big issue. The health literacy, I can't speak enough about the health literacy. I think as physician, as a hospitalist, I've become more of a teacher than I have at sometimes a clinician. I spend time teaching patients about what heart failure is and what it means to have a salt load and what it means to take in the right amount of fluids, which there's arguments back and forth about that, what it means to take care of the right or take your right medications. The side effect profiles is massive on a lot of these medications, and the side effect challenges between different medications at the same time makes it very difficult. And you have to explain that quite a lot. Um, Poor access to healthy foods, and then that's always been an issue. And it's going to continue to be an issue. Readmissions, we have a lot of risk with the readmissions compared to the medication and non-adherence and the limited compliance that we see. And sometimes they just get other medical issues during that time that require them to be readmitted. And frequent ED utilization, we're working on a pilot program with our own ED staff to try to aggressively diurese them before they're admitted, before we accept them into the hospital. But that's a very hard challenge because sometimes ERs are not very comfortable with doing that at times. Please go to the next slide. Why Frye joined the AHA Connected Care pilot? Easy answer is it's an awesome program. And that's not just a plug for what we're doing. It really bridged a gap that we just could not figure out. We had spent, if you've been a hospitalist long enough, as I've been about 15, 16 years, there was also always a gap with heart failure. As soon as you wrote discharge and they left the hospital, there was just, if you've been to Europe or mainly the UK and you say, mind the gap, well, it always felt like we were telling the patient, mind the gap. And I pray that you don't have a readmission anytime soon. And I pray you get to your doctor soon enough. But that wasn't good enough. They were so complex. The patients are so complex now that they have questions 4 days in and no one's there to answer those questions. They can't get to their primary doctor fast enough. They can't get to the heart failure clinic fast enough, if there is a heart failure clinic locally to you. And they don't have anyone to call. So they come back to the ER and they're maybe 1 to 2 pounds volume up. And now you're trying to diurese them and their CKD got out of whack. There just wasn't a lot of ways to mind the gap. So we wanted to address the gaps, as I said, improving the transition of care from inpatient to outpatient is probably the number one biggest thing that we see, not just for heart failure, but multiple other diagnoses. It just made sense to start doing this with heart failure. And some of the takeaways we're going to take from heart failure, we're going to use for other diagnoses. And then also enhancing the goal-directed medical therapy, as Dr. Allen alluded to, we have great medications, but we don't always maximize them perfectly when they leave the hospital. If you're trying to get somebody in and out of the hospital in 4 to 5 days, as most of us try to do, you haven't maximized all the goal-directed therapy just yet. You've started them, but they need maximized over the next couple days. If there's no one seeing these patients for 10, 14, 20 days, nothing's getting maximized. And maximizing those medications appropriately is what keeps their mortality down, it keeps their readmissions down. And then supporting the high acuity populations without somebody there, without some sort of situation to capture those patients and talk to those patients and walk them through the things that could not be addressed when they were in the hospital is so massive for these patients. They get more comfortable with understanding how to look for the signs and symptoms of their body without just walking back to the ER and says, I don't know what's wrong with me, I'm still short of breath. Please go to the next slide. So the American Heart Association Connected Care, powered by Cadence, we already heard a little bit about that. Heart and cardiometabolic care for the patients at home, which is huge after the acute hospital stay. We want to shorten hospital stays because our first goal when we would admit these type of patients is try to get them to the best dry weight as possible without harming so many other parts of their body. And sometimes we can actually get them out just a tad bit sooner with knowing that somebody else is going to look at this very quickly and make some changes if need be. We were one of the 4 hospitals that were invited into this, and we were very excited to do it. It was a heavy lift at first, and we'll talk about some of that. Please move to the next slide. So we started with the patient eligibility. This is screened with the help of Bridget, who is not on the panel. Bridget is kind of my right-hand person. I would say I'm more her right-hand person because she looks at this it looks for these primary and secondary diagnoses of congestive heart failure, looks at their Medicare coverage, and then makes sure that we don't have any exclusions. And these are not hard exclusions to understand. End-stage renal disease patients are not the appropriate patient to be on Cadence. Maybe there's a program in the future that helps that, but when you have end-stage renal disease, it upsets the whole volume of the patient. And if they miss dialysis, then it's not always driven purely by the cardiovascular side of things. Severe aortic stenosis, if you know the physiology behind that, once you develop the heart failure from severe aortic stenosis, you really need to be looking at whether or not that valve can be replaced, whether with TAVR or open heart or whichever. If you're on inotrope supported mechanical dependence, that makes sense. Enrolled already in the CardioMEMS, if anyone knows the CardioMEMS program, we had some patients on the CardioMEMS program locally. Refractory end-stage heart failure, you should be looking for other answers at that point. Active cancer, core pulmonal, and active transplant care. Next slide, please. Key steps. Next slide. Key steps. We talked about a few of these. The biggest thing I would say is identify the right team members. You need a heart failure coordinator, a case management team, a chief medical officer that's involved, or somebody like myself who is the hospice medical director. You have to look at your workflows, pay adequate attention to what you have going on in your own system. There are things that worked really well for us, but didn't necessarily work, that may not work well for the other 3 hospitals. Identify your workflows, looking at your EHR. We have standard consult, summary transmission, provider letter via Cerner that is sent by my coordinator that helps out with the situation. My physicians are very much involved in the collaboration of this. We talk about it with the patients. You get a brochure, a text video, and then the cold call outreach from the Cadence team. Next slide, please. Workflow at Frye. This is just like a generalized workflow. We start pretty early when looking at the heart failure report. This is what Bridget does pretty much Monday through Friday. We look at the eligibility list, Cadence chart review, making sure that we have final eligibility. This is some things that Sean's involved with as well. Sean's my representative as well. Cadence supports the approved patient names back to the heart failure navigator, as I said, was Bridget. She faxes the provider letter. The Cadence team then creates patient chart. Then there's a cold outreach and bedside engagement. The bedside engagement can be done by a nurse, by the heart failure coordinator, by the physician. We just start some way of opening up the conversation. But you have to remember these patients are quite sick during the hospital, so sometimes they don't always want to talk with you right away. But if you keep verbalizing it, sometimes as a lot of us have been told, if you hear it 3 to 4 times, sometimes you start to listen. Next slide, please. I think you can kind of see how it's helped our program so far. It's that bridging the gap that's the biggest issue. Gives us a lot of continuous virtual support that we did not have previously. This is the first of its kind for us. Enhances the medication experience, going over the medication issues, going over medication side effects, what to look for, the monitoring that goes in with that, making sure the patients get to their next viable appointments, trying to make sure that you can head issues off at the pass before you send them back to the emergency department, and continues the structured follow-up and reinforces the right education, because these heart failure patients need a lot of education. And then we create a standard tracking so we can see where we might be having some missteps going forward. Please go to your next slide. Couple things we learned. Traditional heart failure patients are very high acuity in our building with ongoing decompensation. These are very complex patients that we have to spend a lot of time trying to figure out the right mix of medications at that time, and hopefully setting them up for success when they leave. And the Cadence program has helped with that. Even though we haven't had a massive number, we've had a decent number of patients enroll, and they've been doing quite well since then. And Sean can help me out with those numbers afterwards. Significant, unfortunately, do require discharge at skilled when you're talking about the age of population that we're seeing with heart failure. 70, 71, 72, 73, these patients do need skilled nursing facility. Sometimes I have these patients on inpatient rehab, and I've actually called Cadence on inpatient rehab to see if we can set them up after they leave inpatient rehab, and that has helped. Right now we're focused solely on the present hospitalization. We might be able to capture more after discharge, and we're trying to find the ideal kind of sweet spot for our patient population about when to talk to them, because that's been the hardest thing, I think. Next slide. Remaining challenges, like we said, the high acuity, the discharge changing plans. We have a very aggressive desire to discharge patients out of the hospital appropriately. We want to make sure that we're not missing those patients when they do leave. The SNF discharge rate or the skilled nursing facility discharge rate is still pretty high. Social economic constraints we talked about previously. We don't want to overload the provider, but we also don't want to overload the patient with too much information, and the eligibility limitations, of course. Next slide. Thank you for listening for that kind of jamming through the details at Frye. Obviously, we'll be open for questions at the end and during your time. If there's some questions I can answer myself during the rest of the presentation, I will. I will pass this on to our next presenter. Kimberly, are you ready?
Yes, I am ready. Hi, I'm Kimberly Godsey. I'm a cardiology nurse practitioner. As you mentioned earlier, I am also heart failure certified by HFSA. I trained in Cincinnati, Ohio, went to the University of Cincinnati, and worked at the Christ Hospital there, which is one of the main heart hospital. And we are a teaching hospital, research hospital. However, about 7 years ago, I moved out to Monterey, California. And now I work with Montage Health, which is this beautiful building you see before you. It's about a 250-bed hospital in a rural area. We are considered a rural area, and our area is quite large, kind of similar to Dr. Kostic, where we reach deep down into areas of like Big Sur, King City. And a lot of our patients, we have a very big diversity in patients here. And there's a big disparity as from a financial standpoint too, of people that are very, very wealthy, as well as a lot of homeless. And so it presents a bit of a problem trying to keep people out of the hospital. And so I started our heart failure clinic 7 years ago to help try to meet the needs. And I spend a lot of my time always trying to look and pull in different resources for our patients. And I personally found that just like Dr. Kostic said and Dr. Allen, I mean, heart failure is very difficult to take care of and very difficult to manage. And you have to pull in as many resources to help with all of the things that the patients need: patient education, the medications, helping with any kind of social determinants of health. And so our hospital's been working with Cadence in the outpatient setting you can go next slide, please, for about 1.5 years. And so I had really good experience in the outpatient setting with my patients, my heart failure patients. And so when we were approached to consider doing the pilot study for the help with the transition of care from the hospital to the outpatient center, we jumped on board. In fact, it's been a project even prior to joining the pilot study of mine to try to figure out this process to make it easier to help. There's a lot of patients that get lost when you tell them just, hey, call your doctor when you get out and make your follow-up appointment. And again, that get with the guidelines 7-day follow-up appointment, patients leave the hospital overwhelmed, scared. A lot of them, even if they're well educated, don't have great health literacy. And so there's a lot of loss to follow up, and then patients end up back in the hospital. So we started back in May, June, just kind of onboarding to the pilot study, meeting the other study sites, collaborating together, and we enrolled our first patient in October. Next slide. So as we know with the remote monitoring, I think my slides are, at least on my screen, aren't kind of, you can't see everything, but they're not. But they send in the blood pressure cuffs, the scales into their homes, which is great too for some patients who don't even have the ability to afford to buy a blood pressure cuff or a scale. The information goes directly to a website that nurses and nurse practitioners get to manage. And if the patient's vitals are off, if the patient's not taking their vitals, if the patients get a lot of phone calls and a lot of texts. And you have a lot of patients here pretty lonely, and they really enjoy that extra attention. But also, if they identify a patient that there is an issue and they can intervene on it, which is one of the things that really sets the Cadence apart from a lot of other remote monitoring programs that I've looked at. In fact, we've looked at several before Cadence came into our picture, and it makes a huge difference having clinicians that can actually order labs and adjust their medications. And if it gets to a point where the patients are, I got a message yesterday from a patient who was hypotensive and she couldn't get a hold of it. And as a patient I know very well, so we kind of partnered to be able to get a hold of the patient so we could identify what's going on, and help treat it before the patient's so sick that they end up in the hospital. So it's been a really great program in the outpatient setting. So trying to get that transition from, next slide, from identifying the patients in the hospital is the biggest thing. So with the pilot study, you would think it sounds simple. Patient comes into the hospital with heart failure, easy identification, get them enrolled. It's really not that simple. It is a bit time intensive and a heavy lift in the beginning, just like Dr. Kostic mentioned, but it's something we absolutely can do, should do, when we have an ability to do better and have a program like this. So next slide. So this is our kind of workflow. Initially, so identifying patients. So we, a team, myself as a nurse practitioner, I'm primarily in the outpatient setting, but I do go inpatient for our heart failure patients, pulling in all of our cardiologists, educating the hospitalists, the nurses, the discharge planning. It's a whole multidisciplinary team effort. And then trying to figure out, once within our electronic medical system, which we are on Epic, how do we, one, identify the patients and then approach the patient and then put in, and be able to follow the patient through within the chart and make sure everything's charted appropriately, and be able to put in the order. So we are currently have few patients that we've identified and who have agreed to the program. Next slide. But to be able to identify these patients, because they come into the ER and their first diagnosis is shortness of breath, which could be a lot of different things, right? Could be pneumonia, could be PE, could be a lot of things. So we created this registry, and so this is a snapshot of the registry that we created in our Epic system to try to, with the inclusion and exclusion criteria as much as possible. So patients admitted with or having a history of ICD-10 diagnosis of heart failure. So as a lot of you probably know, a patient can come in with maybe after a fall, and then maybe get some IV fluid while they're there. Maybe they have a little pneumonia, so given IV fluid, and they kind of start to have a heart failure exacerbation. So there's a lot. So we want to capture any of those patients who have a history of heart failure, and who also have the traditional Medicare coverage. And then all of the exclusion criteria that Dr. Kostic graciously went through: end-stage renal disease, severe aortic stenosis, core pulmonal, CardioMEMS device, inotropic support, all of that with an exclusion of active cancer. And so we kind of weed through. Next slide. So I run this report every day, and so it comes up where it has the patient's name, date of birth, their primary admitting diagnosis, and the cardiologist. And we'll still go through and look at each individual patient just to make sure that there isn't anything, any exclusion criteria that we're missing. Because some of this is hard, like active cancer. It's not really an easy thing to put into our Epic system to kind of pull out. And so I will run the report and review this with April or the Cadence team each day. In fact, that was what I was doing right before I hopped on this webinar, and looking at these patients individually. Next slide. And so we have in our Epic system, this is April Andler and I, just an example of a conversation that we have back and forth of, is this patient eligible? Is this patient interested? And so we want to make sure that the patient is eligible and we don't miss something that's an exclusion, because the last thing we want to do is offer an amazing program and then say, sorry, can't do it. But there's this constant communication with April. And again, April is with Cadence and I on the patients. Now, once we identify, yes, this is a great patient, they qualify, I reach out to the hospitalist in the same Epic secure chat. It's kind of like, if you're not familiar with it, it's like sending a secure text message within our Epic system, or EMR. And I reach out to the hospitalist or the cardiologist. Our hospitalists also have a care coordinator and the discharger. And I'm like, hey, this patient is a great candidate or qualifies? Do you think they'd be interested? Let's start some outreach. We create the chart in Epic, or not, excuse me, they create the chart on the Cadence side. And then that sends a text message to the patient saying, hey, you are eligible for this program. Would you be interested? On the days that I'm able to go in the hospital and round, I will go to the bedside to the patient and kind of talk to them in more detail. I think Dr. Kostic mentioned, like, the more times these patients hear it, the better, right? The more likely they're going to start thinking, oh, maybe this is a good program. Next slide. Thank you. Because it really takes a coordinated, multidisciplinary team around the patients to be able to be like, to understand this. Now, ideally, what I am working on in our, as the clinical lead in our organization, is really creating the awareness of this. It's still new. A lot of people don't know about it. I've had a lot of patients initially say, what are you trying to sell me? And thinking that it's potentially something that somebody's just trying to make money off of them, which is absolutely not. So we have Sean, who is actually, I think, on his way out to here to really kind of go through. So this week, we are going to work really hard on educating everyone in our multidisciplinary hospital to really understand this program, know what the benefits are, and really start buzzing and have those conversations with the patients on a regular basis, any patient that would qualify. I would love to see this get expanded to Medicare Advantage. We are working currently, we have our hospital system has its own Medicare Advantage Spire. It's called our Spire. And so it's unique to our area. And so we're working on trying to get those patients potentially to qualify. And in my biggest world aspirations for something like this is that eventually, like, these private insurances will cover, because they'll start to see that if we can prove that it decreases readmissions and length of stay, then we can make a big difference for these patients. I mean, if we all know that CMS does not reimburse for 30-day hospital readmission, and so anything that we can do to keep these patients happy at home is ideal. Next slide. So currently, we have, this is not the most up-to-date number. So our eligible patients that we've identified, I think, is around 30. We've scheduled 10, and I think 7 patients actually have their devices and are working it. Saw a patient last week who is enrolled. He said it's great. Helps keep him on track with checking his weight and his blood pressure every day. And that small thing, if we can get our patients to do that every day, that really connects them with how they feel. Next slide. And can help them pick up on their symptoms earlier. Now, just quickly, wanted to show you. So this is some data from our outpatient Cadence program. And because it's still pretty early and we're just starting in the pilot study, just wanted to show you that especially heart failure is in green, hypertension is in purple, that there shows an increase in compliance. Next slide. These are our heart failure patients in the outpatient setting. Once they leave that goal-directed medical therapy, this is kind of an illustration of how they're able to help get the patients on the full goal-directed medical therapy at maximal tolerated doses to help with their heart failure and prevent hospital readmissions. Next slide. So barriers, Medicaid. We have a lot of Medicaid here. That's been one of our big barriers. If we could get the Make America Healthy again to understand that preventing hospital readmissions saves a lot of money. VA insurance, again, the exclusion criteria, or if they're already a member, other barriers, patients are overwhelmed. They're very, very overwhelmed in the hospital. And so they don't know which way is right. And they're trying to even understand what happened to them. And a lack of knowledge or perceived benefit. That, I think, is where our culture of change that we're working on creating within our system will go a long way. And I would love it just to be kind of natural, like, hey, this patient's high risk, this patient qualifies. Let's get them into this program. Next slide. Pearls, the way I've been able to help get patients onto the program, develop a connection with them. just like I do with any of my patients that I'm seeing. Go in, have a conversation, understand what their needs are and what they're thinking about and worrying about first. And then finding a way to be like, I have something that can help you with that. Other things, if we're able, when I go into the room or if the hospitalist goes in the room, if we're able to say, hey, pull up your phone, look at that text message. This is a great program. Let's sign you up now. That creates this nice warm handoff. And then eventually, ideally, patients and staff and physicians will start to see this as the standard of care if, within this study. And so we can talk about it more and help these patients because, as we all know, anything that we can do with these patients that are high acuity, on polypharmacy, with a lot of social determinants of health barriers, any little bit can make a big difference. Next slide. So that's it. This is a picture of the Monterey Bay, where I am blessed and lucky enough to live. Thank you for listening.
And Ryan, let's bring up our panelists. And I don't know, Dr. Allen, if you have some questions, or we'll also be watching questions in the Q&A.
Yeah, actually, the Q&A, I think, has set us up for beginning our discussion off on a few key topics. Maybe I'll actually start with the last question, which is, I think people listening here are thinking about, okay, if I want to do this or advocate for my hospital or health system to get involved in this, so kind of what is involved at kind of the ground level? What's the business model? So there's a specific question that says, is this available nationwide? And I think that actually gets to the question of how does one think about engaging a Cadence with the AHA, reaching out to them, and then kind of immediately it was discussed about how to do the front end work at your hospital. But maybe both Dr. Kostic and Ms. Godsey, if you could kind of talk about what that startup looked like from the ground level.
This is where I was gonna say I'm a little less able to speak to that directly because it started with Sean initially having conversation with our heart failure. So our heart failure coordinator was the first contact, let's say that. And our heart failure coordinator worked through the process of what it looks like for our hospital. Also with LifePoint specifically, LifePoint wanted to be a part of this. So the two hospitals, Rutherfordton and my hospital, are both part of Duke LifePoint's conglomerate. So we figured that once we started hearing about this a little bit, I think I heard about this a couple of years back and it was just a little slow to get going. And when the CMO of all of LifePoint came to me and said, we think this is going to be a really good idea, and he presented it to me, I was like, absolutely, like that's a no-brainer. Of course we're going to do it, because the gap, as I said before, that was massive, and losing the patients in between admission to discharge to the outpatient world was a huge issue. And the way they set it up the way it was explained to us, it made perfect sense. Now, all the nuts and bolts about how the day to day goes was drawn up by a mixture of Sean talking to our heart failure representative. At that point, it was someone else to begin with, and then it became Bridget, and Bridget's just worked through it like expertly with Sean to make sure that we have all the right pieces and parts. So that part of it, I can't necessarily speak to it directly. By the time I got involved, it was easily able to be supported immediately. I took it to my hospitalist and said, you just have to speak to it. And I did like 2 different sessions where I talked about it. And I have about 12 hospitalists that I oversee, I think maybe 11 that I oversee, and they had no problem accepting it. They just wanted to make sure that if we put in a consult for it, the patients were getting more information about it after that. And that was the amount of work that I did. But Bridget did a lot more than me, and so did Sean. So that's the best I can speak to it.
I'd just add a little bit there as well. Thank you, Dr. Kostic. I think really all an organization really needs to do is figure out how they're going to send referrals over or requests for consultation. And you can think of Cadence as a specialist that is being requested for their consultation to assess the appropriateness of RPM. Drop the order, and then start to manage the patient in the program. So what's great is Dr. Kostic's hospital is the Cerner site, and Kim's hospital is an Epic site. So there's a way to do this no matter which EMR you're on. And we figured out a way for them to very easily send electronic order over to us and basically request a consult. Kim talked a little bit earlier about the registry that they're using at the Epic site at Montage, which is really just a rules-based report that shows everyone who's in the hospital with heart failure that meets certain conditions. And then we review that list every morning and basically agree on who are the best candidates for this program. And then we go talk to them about it via phone or bedside visit. So that's really, if you're a hospital on the line today thinking like, what do I need to do to get set up? It's really a patient report or a patient registry within your EMR just to identify the patients. And then it's just a review of that list each day as on admission.
Yeah,
Yeah.
I know. Kim, if you want to talk a little bit about the specific experience in Monterey.
Yeah, so as I mentioned, I'm always looking for new resources and ways to kind of help these patients. We have, and so I work very closely with our quality department, and once you see that look at all of the heart failure hospital readmissions within 30 days, it gets the attention of administration. And so really trying to find ways. We have a digital health department here that I partner with for any of these projects. So it wasn't really tough for us to really get full buy-in from administration. But as far as starting it and getting things going, the biggest piece for me in my experience is working within our electronic medical record. Like Sean said, like creating this registry and making sure that it's done well. And I don't do that part. I work with the IT from the clinical piece, but there's a lot of behind the scenes. And so just creating, the registry within Epic was a big piece, and then just bringing teams together. So myself, our cardiologists, and the hospitalists. And so once we kind of got the Epic or the electronic medical record piece going, it was kind of that everything just took off. And so it's been pretty decent workflow, pretty easy to kind of follow through.
It's good. As a follow-up to that, there's actually a really nice question that just came in, which is, so you're in your hospital, you've generated this report that tries to identify patients who are nearing discharge for heart failure. They have appropriate exclusions, so they need to have appropriate insurance, which should be Medicare. They can't be in another remote monitoring program that would be potentially overlapping with this. They also can't have their care dominated by something else that's even a bigger problem, which would be like end-stage renal disease on dialysis or cancer. So you get this report, you review it, you send those off to Cadence as a referral, which sounds like you've got that built into the electronic record, whether that's Epic or Cerner. And then I think the question is what happens? So we're used to saying, oh, we got to set up our follow-up. We'll see our patient in 7 days. But now they're also in this other program. And so a question was asked, you initiate this during the hospital stay. So then who's following the patient and the remote monitoring data after that? And how does that work in parallel?
So once the order or Cadence is notified, they take it and go with it and get a hold of the patient. Sometimes it's been hard to get a hold of the patient initially, but they keep calling to get a hold of them, or it'll send a text message. They arrange the initial, ideally, while the patient's still in the hospital, a video visit with the patient there so that they can go through the whole consent process and discuss the program, answer any questions, and then they'll set up the next appointment when the patient's going home, a virtual visit, and they deploy the devices right then. We've had I think some patients where they've set it up in the hospital, a lot of patients that actually get set up once they leave. But either way, once they're connected with Cadence is connected with the patient themselves doing that heavy lift, they are the ones who monitor and then will notify us afterwards, and even help with other things like coordination of care, making sure that they have a heart failure follow-up appointment, or if they have other needs going on, like, refer patients back to their PCP and things like that. So, but once the patient's identified, it's really the heavy lift after that is from Cadence.
Yeah, I would say the same thing. Sean's been instrumental at explaining how this works out for us. And as soon as the patient gets eligibility and the letter sent, it's pretty easy from our standpoint. And he extrapolates that information, gets the right patients, makes the right connections. Now, Bridget is involved in making sure that there's some follow-up there that talks about, getting back to the patient. If there's a big question from the physician, we'll go back in the room and communicate. Usually there's not a lot of questions for us, but if there was, we would go back and communicate those. But the reality is Cadence really makes sure that it gets done. So Sean, can you speak to a little bit of that?
Certainly. Thanks, Dr. Kostic. Yeah, I think a lot of a lot of ambulatory primary care doctors and specialists always worry with RPM because all of the vitals go back to them. Then they have to do something with it, and it kind of is inbox fatigue in a way. And one of the things that's really nice about this program is that we are basically acting as an extension to the primary care team, the PCPs in the ambulatory space, and the specialists. We don't want to be the PCP, and we're not trying to be their specialist. We're just trying to act as extenders to those folks to get these patients the care they need timely, and then get them in to see their specialists in primary care. So there's no overlap in codes. We're not taking revenue off the plate of the practice. We're not becoming the physician for them and taking over any of the orders if they have a specialist. What we want to do is coordinate care, get them what they need in a timely manner, and then get them into their already assigned team. So that's kind of how it plays out. We do the monitoring of all the vitals. I think Dr. Allen, you mentioned this earlier. When we start collecting information on blood pressure cuffs and scales for heart failure patients, for example, we have a 24/7 monitoring team that's looking at that. So if a patient over the weekend goes outside of guidelines, we're intervening with them and getting them the care they need. They may not be due for an NP visit for another week, which is fine. And we'll get on the phone with them and take care of what we need to, and then alert their care team with what's going on and send a visit summary to them. Most specialists and primary care are grateful for that because they said, you know what, I would have not known that this happened on a Saturday afternoon, and they appreciate the additional support.
Quick question. Any concerns about overlap for patients with pacemaker ICDs that are in device clinics if they enroll in this program?
Not that I've heard of or seen. I haven't been worried about that, and our cardiology groups would have said this by now if that was an issue, because cardiology in our area is really, really large. We have a large cardiac group, including EP management. We haven't heard any of that. And Sean, you might be able to say that, or Kimberly, you might be able to say something different to that, but I haven't seen it in our area.
No, and I work very closely with our EP team. And most of my patients, or a large percentage of my patients, have pacemakers, defibrillators. There's no concern that I've seen that I can even think of with an overlap, because they're two very different things and services.
And then have you seen your post-discharge follow-up, the way that you construct that change once you started referring patients? Or does this really feel like, as was described, kind of a supplement and add-on to what you were already doing, but you don't necessarily drastically change your outpatient follow-up process?
No, I could speak to that. I see most of our outpatient heart failure follow-ups. And so it didn't change our process at all. I still work on getting those patients into the clinic to be seen within 7 days of discharge to get with the guidelines. So that hasn't changed. But what it does do is, once we get a hold of those patients, like someone's already following them. Like I had mentioned that I was contacted yesterday. That was a Sunday on my patient who was hypotensive. So my process is the same. I just have added help.
That's great. And then we're running out of time. There were actually a couple of questions about cost in there. I think just to emphasize, and Sean, you can add if you'd like to, this is really a referral to an outside agency who then bills Medicare. And, there could either be a copay to the patient, or their Part D supplement could pay for it. But it's really a referral to somebody else. And so the hospital system is not paying for this as a separate, or a hospital service that they have to add. Correct, Sean? I don't know if you want to add to that.
That is correct, Dr. Allen. If you're from a hospital, this should be music to your ears. There is no cost for the hospital, and there is no technical integration needed. So those two things right away, you're ahead of the game. Cadence has become a covered entity status under Medicare, so we do all of the billing, and you can think of us just as a specialist that you're referring or sending patients to, and we're tag teaming the care for that patient. So we take care of all the billing to Medicare. We can order labs and all of that. So yeah, there's no cost. And like I said, there's no technical integration from the hospital side as well.
And it sounds like you said, the hospital's commitment is really to engage the partnership and then create lists of patients, which takes some
Right.
work, and then create processes for interfacing with you all based on the services you're providing and how to react to that. But many of those things are already happening. You know, we're all trying to identify our heart failure patients. We're all trying to figure out how to follow them once they get
Absolutely.
discharged. So yeah,
Yeah,
so a lot of
we've spoken to a lot of hospitals recently, and a lot of them already have the report that we
yeah,
need to identify patients built.
great. All right, well, it's 2 o'clock. I'm gonna turn it back over to Sherry.
Yes, thanks everyone. We've gone to the end of our time. Please sign up for one of the workshops in January. Huge thanks to Dr. Allen, Dr. Kostic, and Kimberly for their participation, and join us next time. Thank you.